Welcome back. I hope you've had a chance to continue to build some connections in our networking function and chat with your peers about learnings from this morning, as well as perhaps gain some points through our gamification competition. We now move to our third panel, technology. New technological advances and digital tools have continued to advance our healthcare sector and have altered the way the NHS will provide patient care in the future. But as technology transforms the level of care delivered, what does this mean for the future of NHS estates and our healthcare teams? New technologies have an impact on the estate in a variety of ways. These changes often have resulted in a better estate for patients, the patient experience, and the well-being of staff. It drives a smarter and more integrated future. So we'll explore how technology is contributing to the development of a far-reaching vision for how health and care will be delivered in the future in the NHS estates. Here to explore the relationship between technology and NHS estates are Christopher King, MRICS, Principal Strategic Asset Manager at NH Property Services, Rishi Das-Gupta, Chief Executive and Chairman of Health Innovation Network, and Dr. David Sneed, pathologist at University Hospitals Coventry and Warwickshire. And as for the last panel, don't forget to submit your questions using the live Q&A function on the right-hand side of your screen. Good morning to you, gentlemen. I hope you're all well. Thank you very much for joining us. I feel on this panel we've just got three guests, so we can breathe a little bit more. So I wondered if we could start off perhaps with you, Rishi, just if we can just do a little round robin about your roles and what you do, which we don't normally have the luxury of time to do. So Rishi, perhaps you can just tell us a bit about you and what you do at the Health Innovation Network.
Happy to do that. And I'm the Chief Executive at the Health Innovation Network, which is an academic health science network. Our mission in the NHS is to spread and to accelerate the spread and adoption of innovations, which can be technology or pharmaceutical innovations across the NHS and make that happen. So we're always looking forwards at what is the next wave of things coming. And I'm joining today to share that as much as anything else. By the way, my chairman will probably not want to hear that I'm taking his job. So
no, let's not tell him. Let's hope he's not listening. Hey, thank you for introducing yourself. David, perhaps over to you.
Thank you, and thank you very much for the invitation to take part in today's panel. As Helen said, I'm a pathologist by trade. I work as a consultant at University Hospitals Coventry and Warwickshire. But I'm better known for leading the charge into digital pathology, and in that vein, I head up PathLake, which stands for Pathology Image Data Lakes for Analytics, Knowledge and Education, and that's a resource that was established through funding from Innovate UK to digitise pathology labs, to build a data lake of whole slide images for research and development, and also to do research to produce AI algorithms that benefit pathologists and patients going forward. And I spend about 50% of my time on that and the rest reporting out cases.
Well, we're going to be finding out a lot more about PathLake in a few moments once Christopher said hello and introduced himself. Oh, he's got guitars in the background as well. I wonder if he's going to play as a tune.
Don't ask to play. It'll be very David Brent-esque, I believe. So thank you, Helen, and good morning, everybody. So my name is Christopher King. I work for NHS Property Services. We are a property company wholly owned by the Secretary of State. We have about 3,000 properties, either owned or under management, and a large chunk of that is the primary care estate. So medical centres, community hospitals, and we have PFI hospitals as well. Within property services, I'm a Principal Strategic Asset Manager, and what my role is that I look at this portfolio of 3,000 properties. And my main aim is to create new business models to bring in new usages, new users into this space, or increase our existing users to drive utilisation and deliver a better utilised estate. Secondary is the information that I provide, and a lot of that data which is driven from technology that we use is used by other teams to be able to, again, try to create a more well-balanced and utilised estate ready for the needs of the NHS going forward.
Gosh, I'm looking forward to exploring that in a bit more detail. A portfolio of 3,000 properties is vast, actually. So a big job there. David, I was going to start with you, actually, if you don't mind, telling us more about the PathLake project, its impact on digital pathology and AI, and what's coming out of it. I mean, sounds a fascinating area to me.
Yeah, so PathLake was one of 5 centres that were established in the beginning of 2019 for the development of artificial intelligence expertise, both in digital pathology and in radiology. So PathLake has focused purely on digital pathology. We are coming towards the end of our funding now, so the project funding will finish at the end of September next year. And our mission was focused in 3 main areas. First of all, to digitise pathology labs here in Coventry and in Oxford and Nottingham and Belfast. And then to use the data which we digitise to develop algorithms with our computer scientist colleagues that would benefit patients and pathologists going forward. So we have exemplar projects running at each of those sites, doing research on data that we've collected that can be used we can hopefully converted into products which will be of use in the future for pathologists. And these range from across the whole piece, really, for cancer finding, for cancer grading, for efficiency gaining tools, and tools which are focused on prediction and prognostication. So a range of stuff, really, which is important for development of care going forward. But as we did that, we realised that we would be in a good position to create a data lake that others could use as well. So not just ourselves, but the community at large. So both commercial and academic groups in this country and indeed across the globe can access our data by applying for access through our access committee. It functions very much like a tissue biobank in that respect. We vet requests for data and assess them on their scientific merit, their ethical issues, and so on, and approve them or not. And those that are approved, then we create access to the data that's needed for the research that they want to do. So we are, I wouldn't say we've completely finished that piece of work by any means. It's a big job to do this, and it's hopefully something we'll continue to build on for many years to come. But it's essential, because without the data there that people can get at and use, you cannot really make progress.
I would imagine, and I hope you don't think I'm being rude thinking of you in age terms, but did you start off your pathology journey and presumably in an age, I'm talking about myself here, I'm putting you in the same ballpark as me, but in an age where it wasn't digital, and has it been incredible being a pathologist and going from more traditional methods to having AI solutions? I would imagine that's been quite an incredible journey and allows you to do so much more and benefit patients hugely.
Yes, I think you're very kind, Helen. Yes, when I started out 20 odd years ago, right up until 2015, really, we were using microscopes for everything, and it was a very manual. Well, it still is a very manual process in that sense. So there's been this huge change to work digitally, and pathologists are often, cellular pathologists in particular, are often seen as the dinosaurs of the age. We still use stains which were created in the 19th century by and large for the majority of our work and so on. So a lot of it's very old-fashioned technology. You go into a path lab, there's no tracking, often there's no order comms, everything comes on paper, you've got people cutting sections, very old-fashioned way of doing work. But it's like that because it works, okay? It does the job, it gives us the information. But you're right, the digitization of the slides is critical to allowing computers to be used then to analyze that data and produce things that pathologists, quite frankly, can't do at the moment. And that's the exciting part. It's very challenging. These are huge data sets. I mean, the orders of magnitude greater than radiology. We're often likened to, PACS imaging and radiology, but it is on a much bigger scale. Everything is bigger and more difficult because of that. And so we've still got some major challenges to overcome. But one of the projects we're kicking off this year is about prostate cancer. We've got 2 actually in prostate cancer, and this is using algorithms already on the market. You could go out, buy them tomorrow, put them in your lab and use them. They've gone through regulation. So these things are arriving and will continue to do so for the next few years.
I think that's something we'll explore in a few minutes when we've chatted to Christopher and Rishi more. I'd like to ask about, how AI is affecting cancer types, etc. Christopher, just bringing you back into the conversation. How is NHS Property Services using data and technology to optimise the NHS estate? You mentioned there you've got 3,000 plus in your portfolio.
Yeah, so I think as a company, we've really over the past few years used technology, really embraced technology to try and optimize the NHS estate and really try to improve the service offering that we have, not just for our own portfolio, but we want to be the asset manager and be able to advise the wider NHS itself. So I think, a couple of examples. I think the first off, when COVID hit and we all went into lockdown, we started the Smarter Working Programme. And that was investing heavily to keep our employees connected in lockdown. So that included equipment for either home working or providing all of our frontline staff with things like mobile phones to make sure that they work at a stage when we all stay connected together. And we're currently going through a reimagining of our office estate. I don't think really only people who are doing this. I think it's quite a common theme now, whereas offices going forward are not going to be seen as somewhere where you go and sit and write a report and do your emails. It's more about collaborative face-to-face working. So we're actually transforming our own office estate to meet that requirement going forward. A second area is we are as a company committed to being a carbon net zero company. And we are using technology to deliver either new sustainable developments or to upgrade our existing portfolio. And that's whether we're using renewable energy sources or implementing hybrid technology and process procedures to, say, reduce power at quiet times. I think that the third example, and probably the one that I'm most involved with, which is NHS Open Space. And I guess the best way I can describe this, think of it as a Rightmove meet Booking.com style offering where users can get easy access to book clinical or non-clinical rooms. These can be hired on an hourly, a session or a daily basis. And what it's enabling us to do is not just retain our current user base, but attracting new users because they're now getting easy access to that space. That then in turn increases utilization within the estate, which is what we want to see. And the most important thing is it always filters down to the patient. So if we can get more people in providing services, that's more choice for the local community. And it's not just the booking system. We use sensor technology as well as our own reporting tools to understand how that space is now being used. We never had that before. We now know exactly who is using that space, how they're using it, and it's providing us with invaluable data to be able to manage not just that part of the estate, but then use that data to be able to provide it to the wider estate, and that can then feed into estates planning going forward.
Brilliant. We'll dig a bit deeper on that in a moment. I'm just aware that I've ignored Rishi for a few more minutes there. Rishi, you've got innovation in your title, which I always find exciting. There's a lot of work going on, isn't there, to improve patient self-care and remote monitoring. And how will this affect the use of outpatient clinical and administrative space, do you think, in the hospital?
Well, I think we're looking at quite profound changes, actually, and it's all been accelerated. And I think they were always coming, but it's been accelerated through the pandemic. So as you said, the sort of patient self-care, remote monitoring, we've seen a lot of work in creating virtual wards to have patients who otherwise would be in hospital at home. We're seeing a lot in outpatients to reduce the number of visits that people have to hospital and do more at home. And I think that what often is missed in that is that the nature of what we do in our clinical sites therefore changes and becomes more intense and requires more resource when you're actually in a facility. So I think that means that, if you're coming to outpatient visits, you're probably going to have some tests at the same time. If you're in an inpatient area, you're probably at the more ill end of the spectrum. and so there'll be more equipment, more stuff around, and you actually need more physical space for some of that stuff. So I think that there's a real requirement for flexibility and a shift that's coming there. And then you mentioned the administrative space, and so did Chris. I think that's really important. But David, as you were talking, the acute hospital that I used to work in, the digitization of pathology offers the opportunity to kind of move the physical space where you're getting the samples and making the slides to where you're reporting them, and how that works. And again, you can see some of these implications as we go. And then Chris, as he was talked about sort of sensorizing the buildings and how we do that. I used to be a clinician and have worked in operational management as well. We would love to have more sensor data about how sites are being used to streamline the particular day case and the inpatient facilities where there's an awful lot of stuff going on. And I did pre-pandemic go out to the States and see some of their facilities where completely reimagined, the way that we provide outpatients, so that you have things, a patient is roomed or put into a room, and then everything moves around them and services come to them while they're in. And that's enabled by a lot of smart buildings technology, a lot of sensors to see what's happening where, and supporting that into the workflows. So that's sort of a very quick overview of many of the changes that I see could happen and the way the pandemic's accelerating.
Mine must boggle sometimes with actually what's out there, because the change has been so rapid, really. I mean, even in the few years that I've been hosting these conferences, the change in technology and digital and innovation has been quite amazing. Rishi, what additional requirements do you think are there for diagnostics in healthcare environments?
Well, we're seeing a lot more sort of point of care testing equipment being available, and David will probably have a sense of this as well. And so looking at sort of outpatient spaces, often cram the rooms together, but then you need space to actually do tests nearby where the patients are, rather than having people traipsing around a large facility. The second bit, I think, is that we're seeing a lot more work being done on screens, and for our staff to be healthy whilst they're working for a long period of time, we've got to have sufficient space for them to circulate, move around, the right equipment, the right infrastructure in to support that technology. Particularly, Wi-Fi is everywhere, but we're now talking about multiple different forms of Wi-Fi and to support IoT devices as well. So there's quite a lot of the infrastructure that needs to go alongside that, which, as many of the people on this meeting, I'm sure, appreciate, it's hard to do in old buildings, isn't it? So.
Right, so it certainly is. I'm looking forward to the newer hospitals of the future. I mean, David, feel free to pick up on what Rishi was saying there, but then I was going to ask you about AI in prostate cancer, and in fact in other cancer types. But do you want to pick up on what Rishi and Christopher?
Yeah, no, absolutely. There's a lot of money that's being made available right now, actually, to support digital pathology and upgrade limb systems within pathology as well. So the market is absolutely buzzing at the moment with activity in this area, and it's been a huge change. Obviously, the pandemic has been a catalyst, I guess, to really galvanize everyone to take this step. I think prior to the pandemic, I had many conversations with consultant colleagues who were either reluctant or skeptical about working digitally and couldn't really see the point. And now, sadly, of course, everyone can only see too well what the point is, really. Yes, the work is mobile, you can move it around, and you can work off-site, and you can do that very, very efficiently. But it requires infrastructure and support beyond just buying the kit. And I think that's the one I would flag up most, actually, is IT. I fear for IT directors across the country in NHS, because they must be just completely flooded with requests and requirements, and they are clearly all doing a fantastic job, but nevertheless struggling, I think, just to keep pace with the demand of change. And we need to look after them and support them in delivering what's needed going forward.
Absolutely. Moving on to the AI solutions in prostate cancer, why are those the first AI solutions that be using,
Really
and how will it affect the diagnosis of prostate cancer?
So I think why it was the first, I think, is probably just a coincidence that prostate was seen as well. First of all, it's a major cancer type, which is causing a problem in many healthcare services across the globe. With an aging population, we're seeing more cases and having to deal with more cases, and they're very difficult. Prostate cancer is not an easy thing to diagnose. So I think those two things are what's really focused attention at this area, because it's a difficult task to first of all get the samples from the patient, and then also a difficult task for the pathologist to analyse those samples correctly and provide the correct report. So AI might help a bit with the first, if you're in terms of radiology, but I'm not really talking about that today. It's more about the analysis of the slides, which I think is going to be the big change. So there have been two companies which have focused on prostate cancer, and they're both well known in the AI circles, and have got their tools through regulation about the same time. And we are interested to know just how effective those tools are in routine practice. We know what the research tells us, and the results are very, very promising, but we don't know how that translates into what we would call the real patient world of what we're all inhabiting. So so that's what these two projects we're running this year and next will do, and they'll measure performance of the AI against the existing standard, which is of course pathologists. What will it do? It will first, I think it will do two things. It'll make the process more efficient. So it'll find cancer for pathologists to examine and check. And that's a big help, because sometimes, I'm not kidding you, we get maybe 120 samples from one patient. And if you've got to go through every single core to find the cancer, that in itself takes hours of work. So if you can do that and say, it's here, look at it, and all you've got to do then is just check that is correct, the correct diagnosis, you've saved a whole heap of time there. And the second thing is, it's going to find cancers which would be missed otherwise through the fact that they're very small, first of all, difficult to spot, that they get obscured by artifacts, pathologists get tired, etc., etc. They get missed, okay, and so we know that because we've examined samples which have been signed out in labs before. So that's we know what it is. We don't think that's a massive problem. I think it was a massive problem. We'd know about it because patients would come back with more advanced disease. But we know it's an uncomfortable truth that low-grade prostate cancer in particular can be easily missed in biopsies. So the AI will help prevent that. And the third thing it's going to do is, hopefully anyway, is make the grading of the cancers more robust, less open to observer variation, if you like, which is what is difficult at the moment. When you're making big decisions about whether to treat patients radically or not, you don't want any variation in that grading, okay? You want the same result to come out of every single lab across the country all the time, and that's very difficult to deliver with human observers for obvious reasons. We work very hard at it. It costs a lot of time and effort on everyone's part to ensure we do that, but it is difficult, and AI will help in that battle.
Brilliant. Thank you very much, David. Exciting times, I think, ahead for you there. Christopher, just moving back to you, you talked about open space. I don't know whether you wanted to just finish off on open space, but will it be available in non-NHSPS buildings in the future? It sounds like a really good and positive thing to me.
Yeah, so just before I talk about open space, just to come back with David and Rishi, I think one of the reasons why I really enjoy doing these things is it's so heartwarming just to hear that there are other people who are using technology and really want to use it to improve the NHS. And it's, Rishi mentioned about the fact that, the building stock and about how some of it is quite old and how difficult it is to upgrade. I think that is one of the biggest challenges that we have to meet as property services and other NHS landlords. And it's so important because we should be seen as an enabler for people like David, who's at the cutting edge of providing this technology for the benefit of patients. And we need to make sure that we provide the estate to be able to facilitate, not to be able to hold that back. And one of the things, and so that's what drives property service, and what we're trying to do is to try to deliver a fit for purpose modern estate, so that people like David and people like Rishi can then do what they're doing, without having to worry about whether there's the right Wi-Fi, or whether there's the right tech to enable them to facilitate that. With regards to NHS Open Space, so we are on, I'd say we're kind of in the middle of our journey at the moment. We started with a 2-year pilot, and that was really just to understand what everybody wanted. The way we set up the program is that it had to work for everybody, not just us as a landlord, but it had to work for the patients, it had to work for the people providing the services, it had to work for the commissioners. So we conducted the 2-year pilot, and then we launched in April 2019, right just in time for COVID to hit. So that delayed our rollout for about 6 to 9 months, but we're currently national. We're at 150 properties, about 1,000 rooms so far, and we're adding another 50 to 60 properties and another 200 rooms pretty much every 5 months at the moment. We expect within a year's time to be up to 250 properties and about 1,400 rooms, so to have a real national coverage of available space for people to come and use. Now that is at the moment purely with our own portfolio, and that was a conscious decision we made, because we wanted to make sure that we were testing every aspect of this before we rolled it out to the wider health economy. I think going back to COVID, what this has done is it's really changed the way that people look at how space is being used, and there is now a huge demand for a similar product and the surrounding business model, in how to essentially set up, run and manage flexible space, either clinical space or actually within the office sphere as well. So we are actively looking into the next stage, and the next stage would be providing this to the wider healthcare system, so that other NHS landlords can essentially put their properties, actually use open space for their own properties. And we can do this in one of 2 ways. The first is that we could provide it as a standalone system for them if they wanted to have an internal system to use. And then the second is to create a marketplace style. So think like, again, as an analogy, Amazon, where you've got multiple sellers selling, their goods on Amazon now. It'd be a similar thing to open space, whereas we'd have all of our properties on a single platform, and other landlords, other NHS landlords, can put their own properties on there. And so all of our properties are available in one location. And what that does is that it means that if you're looking to commission a service, or if you're in a particular area, you'll be able to do an area search for, let's say, 2 clinical rooms every Monday and Tuesday morning for the next 2 years, and within a matter of minutes, you would have found all of the properties available, selected and booked those properties, as opposed to what's happening at the moment is that you would probably have to do a Google search for those properties and then ring up each one individually to see what space is available. So the idea
will be much more familiar with open space. You're rolling it out very quickly.
I hope that's the idea.
Okay. Yes, Richie, I just want to bring you into the conversation before we break for lunch. Of course, we talk about sustainability. We talk about the NHS's journey to net zero and the targets. How will that sustainability plan and our aim for net zero affect clinical sites, do you think?
I think there's several bits to that. So the first is, we talked briefly about remote tech and how that's helping reduce travel, and that's a real impact on the way that what is generating our carbon footprint. The second big bit, I think, is around improvement on which pharmaceuticals we're using, how they're packaged and working through. But the third one that's probably the most relevant for our estates is sort of how we use energy in our buildings, the size of the buildings, and how that shapes up. And many many of the people on the call will know, you know, the amount of circulating space we have, the size of the waiting rooms changes.
Yeah.
I think what Chris was describing is a really, and open space in general, is a really welcome way for us to unlock the way the estate works. I don't think any of us are in doubt that we're going to have to embark on a large hospital building. And so I'm not going to say hospital, actually, because it isn't all hospitals, but a large healthcare facility building program.
Yes. Better word for it, actually, isn't it? Healthcare facility.
Yeah, and those are going to look, I think, a bit different to what we have at the moment. So I think shaping up what is available in our current stock is really important, and Chris's team are doing that. I think looking forwards, there's going to be an increased need to have spaces where people can discuss care, because, you know, medicine's now a team sport. You know, we want David in the room with us as we talk through management plans. So doing that either physically or virtually is really important. And the doctor's office, where you've got a collaboration room, in the future probably has someone joining virtually in that meeting as we go. So the multidisciplinary team rooms look different. I think the other big bit that's changing is the way that we interact with the computers is changing. Yeah. So looking forwards, there's quite a lot of speech recognition tools and ways of navigating the IT that we use that will not be dependent on us typing at a keyboard in the corner of the room. In dentistry, I've seen quite good ambient microphones set up to be able to record onto medical records remotely. And if we think about that in the environments we've got, you know, being able to do that in a cubicle with a curtain around it probably isn't the way forward. So we have to think about the way we soundproof the rooms, the way that we plan that. And I think all of that needs to be built into making sure that when we build our next wave of hospitals, in addition to being energy efficient, and we get them the right size and the right amount of flexibility, that we can accommodate these changes in the future without having to then build another wave of facilities. So,
just briefly, Rishi, because we have only got 30 seconds before lunch. Are we likely to see then, and is there a need for innovation hubs, if you like, in our, not just hospitals, but in our healthcare centres?
No, that's a good question. I think there's a need to try all this stuff out, because we're constantly having to change it, and that analogy of building the aeroplane while it's flying is very real. So lots of places are having sort of simulation centers or innovation hubs, which are a bit like the rest of the facility, that you can try something out in before you then go and roll it out further. And, you know, Chris described the way that they've got it working in a smaller number of sites before then doing the rollout. So I think that is coming, and it's a good question.
There's so much more I want to ask all of you, actually, but it is our lunch break, and obviously there's important things to do, like networking at the lunchtime. So it's time for me to say thanks to all three of you, to Christopher, to Rishi, and Dr. David, for an in-depth look at this topic, and a fascinating one as well. Another where I feel there's still so much more to uncover. So I hope they'll join us at another event like this. It's been an interesting discussion, and it's time to let you, our audience, digest all of that knowledge and the insights that have been shared, because lunch is coming up soon. So if you have a chance, do jump into the meeting hub and continue to gain connections and build your community with your fellow delegates, or chat further perhaps to those that you've already met. I hope this morning's given you food for thought. My mind's like full of ideas and thoughts, and maybe some topics to break the ice. The connections you build now are there for you to use into the future, logging in at your leisure and exchanging views with not just the delegates here today, but future registrants too, really building up your community. Our speakers, of course, can offer you plenty of knowledge, but a significant source of knowledge on our platform comes from each and every one of you. So do feel free to share your insights too, and realize their value. A reminder, we have a great and rewarding prize for those fully taking advantage of community building. Those in first, second and third places will get to donate in their name to the Magic Breakfast or More Trees. Our next session starts at 2 o'clock, so enjoy your lunch. I'll see you then.